Good afternoon, Professor Kalangos. It's a great opportunity for me and a privilege to be a speaker in this excellent conference that is held in India. Uh, Professor Kalangos is my mentor, and I would like to thank him for all his hard work all these years to improve me as a physician and a person. So my talk now will be be different than what is the previous talks. I will try to emphasize giving a talk on which views we have today and which strategies so we can be more significantly accurate in an early detection of congenital heart disease in low and middle economical countries that will help the outcome of these patients, taking in consideration all the existing resources that are missing from these countries. So, first of all, greetings from Athens, and I have no disclosures. What I would like to emphasize, and this is well known to all of you, is that every 15 minutes in a part of the world, a child with congenital heart disease is born. 50% of these children will die if we don't do anything in the first month of their lives, and 50% of the deaths that occur in the first year of their lives are due to conditions that we call severe congenital heart disease. Now, the topics of my discussion is how to arise the suspicion to all the medical staff that is involved in a pregnancy that will deliver a baby that has congenital heart defects. What is the role of the obstetrician gynecologist? How will we increase the detection of congenital heart disease in the early postnatal period? What is the role of a neonatologist that will be called upon the delivery? The role of a pediatrician that will be able to diagnose a severe type of congenital heart defect in the first few weeks after the delivery? What is the role of the pediatric cardiologist? And my take home message. So, most common congenital heart defects are the most common congenital malformations or congenital heart defects. And you can see here a prevalence that is more than what we see in the Western world, that can rise up to 1.6% in different countries in which we have special conditions that create inbreeding of the disease. 10% will be early spontaneous abortions that will be mostly to very severe congenital heart defects that are not capable to sustain a fetal circulation during pregnancy. Now, 50%, as I said before, will be the critical conditions in which something will need to be done in the first month of the life, surgically or interventionally, and 50% will be the deaths that are related in the first year are setting the page of the severe congenital.
Sorry, Andreas, for interrupting you, but we cannot follow your slides.
So, as you see on this slide, we have a prevalence that in some countries is more than what we see in the Western world of congenital heart disease, and this is due to special inbreeding conditions in some countries. Now, the definition of critical and severe congenital heart disease is well known, and I will focus on these types of congenital heart disease because these are very important for the severity of the child. Now, as we know, the embryogenesis of cardiovascular disease happens in the first 2 months after conceiving the pregnancy. Both pulmonary and systemic circulations are in parallel, and you can see that during the embryogenic period of the creation of the cardiovascular system, we have specific anatomy and physiology that sustains low saturations. So the postnatal circulation is a very important element for the early detection of critical and severe congenital heart disease. So I discussed the prevalence of congenital heart disease before, and I come now to discuss what used to be. We were able to screen early for congenital heart disease. I want to remind to all of you the excellent job of Dr. Virginia Apgar, who first in 1952 came up with these 5 very easily clinical signs to detect conditions in which babies needed to be resuscitated. Through the job of Virginia Apgar and the Apgar score, we had a screening program that was, as you see, evolved from 1960 up to 1970, 1980, and 2000 for different conditions of congenital defects that are very important for the to lower morbidity and morbidity and mortality of the babies. But we needed to come up to 2012, where we started to have a program of screening for critical congenital heart disease. And this was adapted in the screening program of the United States during the period 2011 to up to 2013. Now, what is this breakthrough program? This breakthrough program, okay, as you see in the slides, helps us to detect something that is more common than cystic fibrosis, hypothyroidism, PKU, or metabolic disorders. And this is the critical congenital heart disease. So how do we do this? And which of the critical congenital heart disease you can see on this slide, stating the hypoplastic left heart, pulmonary atresia, TOF with an absent pulmonary valve, double outlet right ventricle, types of total anomalous pulmonary vein drainage, complex TGAs, tricuspid atresia, trancus arteriosus, and other very severe left heart obstructive disease as interrupted aortic arch. And this is a paper I have published a few years ago showing that these diseases either have a cyanotic component or have a low perfusion index. And basically, if we put together the cyanotic component and the low perfusion index, we can probably use in pulse oximetry able to detect these conditions. Okay, so let's go back a few months in the pregnancy and see the role of the OBG and how he will set the possibility of having a congenital heart defect. First of all, being able to see the maternal risk factors for congenital heart disease, as the past medical history of the mother, the family history, if mother is obese, if diabetes mellitus is present, if mother takes any kind of medications that can create congenital defects, the lifestyle of the mother, the environmental hazards, and other conditions. Now, he can also assess fetal risk factors like nuchal translucency, fetal hydrops, arrhythmias that can happen in the fetal heart, mostly using the 20-week gestational age scan, or if we have any chromosomal abnormalities or extracardiac abnormalities or an IUGR baby that has been picked up on the different scans or the 20-week scan. Now, prenatal evaluation can be done by fetal cardiology, but this is something that we cannot find easily in low middle economical conditions because it's still a very sophisticated, expensive, and limited in many countries ability The indications for a fetal cardiology assessment is based on diabetes mellitus, infections during pregnancy, teratogenic agents, an abnormal four-chamber view during the 20-week anomaly scan from the OBG, a family history of congenital heart defects, chromosomal abnormalities or extracardiac abnormalities. Dextracardia is always an indication to check this heart, situs inversus, an IUGR baby, as well as fetal arrhythmias. And although you can see that today we can do this investigation between 11 and 14 week, okay, the majority is still done between the 20th week of the pregnancy. Sensitivity and specificity is very high, but as I said before, it's an expensive examination, and many countries do not have a lack for these kind of examinations. And now just put a slide to remind you that today we have also prenatal treatment of congenital heart disease, not only medical through fetal arrhythmias, but also when we have a severe aortic valve stenosis or a severe pulmonary valve stenosis that can lead to a left or a right heart hypoplastic condition, we have today the ability in cases that have been very well selected to have an interventional procedure with a balloon procedure through the abdomen of the mother and the uterus to balloon this valve and change the outcome of these patients. Many of them, they will be able to have a two ventricular repair. Continuing my presentation, okay, I will come to the role of pulse oximetry. Pulse oximetry is something that we have been used, as I showed you before, in the screening tests in United States since 2011 and mostly 2013 and there above, and also in Europe. With the use of a pulse oximetry, the sensitivity to detect a critical congenital heart defects is nearby 77%, and the specificity is also high. But also, we have another goal that we can achieve using this very easy to use and very cheap examination. We can detect sepsis and respiratory disease in the first 24 hours of the birth of the baby and then act accordingly to treatment plans. This does not replace an echo 2D clinical examination for a baby that we suspect that has a congenital heart defect, but helps us always to set the scene of a possibility of a congenital heart defect. And on this slide, you can see how easily it is to obtain the test, because the only thing you need is to measure the percutaneous pulse oximetry on the right hand of the baby, that is a predactal part of the body, and in any limb, either the right or the left, to detect what is the pulse, what is the saturation of this baby, and if the saturation is normal, and normal will be, as you see on the slide, over 95% when we have obtained the first day of the baby as life. The difference between pre and post dactyl saturation must never be more than 3%, because if it's lower than 3%, if it's more than 3%, this sets the suspicion of a coarctation of an aorta or a severe left heart obstruction. And you can see on this slide the European guidelines of using the pulse oximetry that have been published from the Hellenic Society of Perinatal Medicine in 2021 and are used today in Greece to detect easily and suspect these children that have the defect. Now, as you see, what you need is 3 only measurements that will be done after the first 24 hours of a term baby, and we need these measurements not to fall under the normal value of 95% for the pre and post dactyl measurements. A comparative cost that comes from United States shows us that we have approximately about 10,000 cases per year of critical and severe congenital heart defect. Screening by ECHO-2D will cost an additional cost of about 40 million per year if we wanted to screen all these possible babies. A metabolic disorder screening in the United States for 6,400 cases per year has a metabolic cost of $7,000. The cost of the pulse oximetry is only under $87,000, and this shows that the screening test cost is only $8.67 for all the children. And this shows us what will be the tax saving per year if we have a pulse oximetry measurement for the babies that we suspect that will have a critical and severe congenital heart defect. Now, moving to the role of the neonatologist. Well, the role of the neonatologist is very important because the neonatologist, to detect an early congenital heart defect, is something like the queen during a chess game. We have the ability of using all the information from the OBG history, a physical examination that can give us clues of this condition, and also, as we discussed previously, to use the pulse oximetry test so we can suspect which babies probably can suffer from a critical or a severe congenital heart defect. Now, if the baby has any of these symptoms that you can see on the slide, makes the possibility of having a congenital heart disease even higher. And I'm now showing you the 3 basic presentations of the babies with congenital heart defect. The presentation of cyanosis, and I'm just putting the slide to remind you the blind spot of trying to detect clinically cyanosis is based on the amount of hemoglobin of the baby. So if the baby has a lower hemoglobin, the clinical presentation of cyanosis will only occur when the saturation is less than 78%. But if the baby has a hemoglobin of 17.5, then you can pick up the clinical cyanosis even when the saturation is 83%. But it's not only this what we are gaining from detecting cyanosis. We are gaining also the opportunity to detect primary pulmonary hypertension of the neonates, primary lung disease, and also put in our differential diagnosis the congenital heart defect, and showing that the first 2 of these conditions improve their saturation and the mean pressure of oxygen in blood gas if we obtain oxygen 100% for these babies. But this doesn't change in the congenital heart disease with a cyanotic presentation. The other clinical presentation is the baby that has decreased systemic perfusion, so something like a low cardiac output syndrome, with all the clinical presentations that seem to be also in our differential diagnosis common in sepsis, in anemia or polycythemia, in metabolic acidosis, in hypercalcemia and hypoglycemia, in myocardial dysfunction that can happen because we have a very difficult delivery that takes time, or if we have an obstructed heart disease, mostly a left heart disease. So a decreased systemic perfusion must always be in the back mind of the neonatologist, that it can hide not only more common neonatal conditions as sepsis, but also a severe obstructive heart defect, mostly left heart defect. Now, the final presentation for the neonatologist is tachypnoea. And what I want to tell you is that tachypnoea is a sign of congestive heart failure only secondary to congenital heart disease, but never presenting from birth, with the only acceptance of the obstructive type of total anomalous pulmonary vein drainage patients. So when we have tachypnoea from early stages, and mostly this will be seen when the duct closes on the second or third day, we need to think about severe aortic valve stenosis, severe coarctation, or interrupted aortic arch. And this will increase the suspicion of the neonatologist that probably we have a congenital heart disease that needs to be attended. I put a slide from Ellen Towson, who is the mother scientist of pediatric cardiology, to remind to the younger doctors that it's very important to examine by physical examination the patients, because they can give us so many informations that will increase our susceptibility towards congenital heart defects. Now, I don't know if you can be able to see this slide, but this slide shows us, again, the algorithm we use to detect children with severe and critical congenital heart disease, taking in consideration a low perfusion index and a low pulse oximetry measurement. Now, the role of the neonatologist is to suspect the detect and detect as early as possible a possible congenital heart defect that can be critically severe. Okay, and then to stabilize the neonate before surgical or any interventional management, and to be alert for late onset presentations of these conditions. I'm coming now to the final part of my presentation, that is the role of the pediatrician. Now, the pediatricians will check the child after the first week of its life, or maybe on the 6th week well baby examination, where the pulmonary vascular resistance are now normalized, and a murmur can also indicate the possibility of a severe congenital defect like tetralogy of Fallot that has not presented up to date with visible cyanosis. So again, the take-home message from this slide is that the pediatricians need always to use a pulse oximeter and measure a pre and post-ductal saturation that will help them to finalize their suspicion or to exclude a congenital heart defect. So, what is the role of the pediatric cardiologist? To support these neonates, to explain why a failing oximetry test existed, to establish the diagnosis, to exclude differential non-cardiac diagnosis, to support medically these children until they are referred appropriately for an interventional or surgical treatment, to explain and support families facing critical and severe congenital heart disease, and to support the work of the NICU. Now, as a summary slide, you can see all these different stages we discussed, with the possibility of the OBG putting the initial possibility of a congenital heart disease through the medical history or the fetal examination of the baby, coming down to the 20-week anomaly scan, coming down to the pulse oximetry test, and finally coming to the neonatal world where a hyperoxia test can show us that we have a cyanotic or not cyanotic condition of a critical disease. And finally, my taking home message is that cardiac defects are frequent in neonates and difficult to diagnose when fetal circulation persists. Pulse oximetry is an excellent screening tool. Physical examination is vital and must follow a pulse oximetry test. Differential diagnosis is essential and life-saving. Initial life-saving treatment must be offered by neonatologists with no delay with the support of pediatric cardiologists. Pediatricians must be aware of late onset of critical congenital heart disease, and referral to a pediatric cardiologist establishes the diagnosis. And before I close and thank you all, I would like to invite you to the first International Balkan Conference for Congenital Heart Disease and Cardiac Surgery, in which the president of the conference is Professor Kalangos, and it will take part in Athens between 13 and 15 March 2026. And with this beautiful picture I hope you see from a Greek island, I want to thank you, and I apologize for the technical issue on my slides.
Thank you very much, Andreas. Excellent presentation. Don't worry about the technical problem. Do you have some questions from the audience? No. I have a question because now in the screening, we have this handheld smartphone size mobile echocardiography. What do you think?
Well, if we come up to the level that it can show us images of neonates that have a weight of 2.5 to 3 kilos, I believe that this will be an excellent tool for neonatologists and doctors that will be as soon as possible on site to detect a congenital heart defect. But I want to emphasize once more that the need of a pulse oximeter test that is extremely cheap and very easy to use is one of the breakthrough conditions that help these babies to be detected in low and middle economic countries.
Thank you very much, Andreas.
Thank you, Professor.
Thank you. Thank you.